Welcome to today's session. I am Dr. Jemisha, working as Assistant Professor at Emmanuel Arthur College of Pharmacy. In this video, we are going to learn about pharmacotherapeutics of diabetes mellitus. Diabetes mellitus is one of the most common chronic metabolic disorders worldwide. It is not simply a disease of increased blood glucose. Persistent hyperglycemia can affect almost every major organ system and can eventually lead to complications involving the eyes, kidneys, nerves, heart, and blood vessels. Definition: diabetes is a group of metabolic disorders characterized by chronic hyperglycemia resulting from defects in insulin secretion, insulin action, or both. The most important feature is chronic hyperglycemia, which means that the blood glucose concentration remains elevated over a prolonged period. Why does glucose increase? There are two major possibilities. First, the pancreas may not produce enough insulin. Second, the body may not respond properly to insulin. This is called insulin resistance. In some patients, both problems occur together. Insulin has an important role in carbohydrate, fat, and protein metabolism. When insulin is deficient or ineffective, glucose cannot be properly utilized by tissues. Hepatic glucose production increases and blood glucose rises. Over time, persistent hyperglycemia produces vascular and neurological damage. Therefore, diabetes is a systemic metabolic disorder rather than simply a disorder of blood glucose. Next, normal glucose homeostasis. After we consume food, carbohydrates are digested and glucose enters the bloodstream. As blood glucose increases, the pancreatic beta cells detect this rise and it releases insulin. Insulin acts mainly on skeletal muscle, adipose tissue, and the liver. In skeletal muscle, insulin increases glucose uptake and promotes glycogen synthesis. In adipose tissue, insulin promotes glucose utilization and fat storage. In the liver, insulin promotes glycogen synthesis and suppresses glucose production. At the same time, insulin suppresses processes such as gluconeogenesis, glycogen breakdown, and lipolysis. The overall effect is a reduction in blood glucose toward the normal range. Next, classification of diabetes mellitus. Diabetes mellitus can be broadly classified into four major categories: type 1 diabetes mellitus, type 2 diabetes mellitus, and type 3 diabetes mellitus, which is diagnosed during pregnancy. The fourth category consists of other specific types of diabetes. Type 1 diabetes is primarily associated with destruction of pancreatic beta cells and absolute insulin deficiency. Type 2 diabetes is mainly associated with insulin resistance combined with progressive beta cell dysfunction. Gestational diabetes develops during pregnancy and is associated with increased insulin resistance. Other specific types can occur because of genetic defects, pancreatic diseases, endocrine disorders, certain medications, and other underlying conditions. First, type 1 diabetes mellitus. Type 1 diabetes mellitus is primarily caused by destruction of pancreatic beta cells, most commonly through an autoimmune process. The beta cells are responsible for producing insulin. As beta cell destruction progresses, insulin production decreases dramatically. Eventually, the patient develops absolute insulin deficiency. This is why insulin replacement is essential for patients with type 1 diabetes. Type 1 diabetes often begins during childhood or adolescence, but importantly, it can occur at any age. Patients may present with classic symptoms such as excessive urination, excessive thirst, increased hunger, and weight loss. Because insulin is severely deficient, patients are also at risk of developing diabetic ketoacidosis. Therefore, the major pharmacotherapeutic principle in type 1 diabetes is that the patient requires insulin. Next, type 2 diabetes mellitus. Type 2 diabetes is the most common form of diabetes. Unlike type 2 diabetes is not usually caused by complete absence of insulin at the beginning. Instead, the major problem is insulin resistance. Insulin resistance means that tissues such as skeletal muscle, adipose tissue, and the liver do not respond adequately to insulin. Initially, the pancreas may compensate by producing more insulin. However, over time, pancreatic beta cells become dysfunctional. Therefore, the patient eventually develops relative insulin deficiency along with insulin resistance. Type 2 diabetes is strongly associated with obesity, physical inactivity, unhealthy dietary patterns, family history, and increasing age. Treatment may include lifestyle modification, oral medications, injectable non insulin medications, and when necessary, insulin. Okay. Next, the third category is gestational diabetes mellitus. Gestational diabetes refers to diabetes diagnosed during pregnancy that is not clearly pre-existing diabetes. During pregnancy, several hormonal changes occur. One important change is an increase in insulin resistance, particularly as pregnancy progresses. Normally, the pancreas compensates for this increased insulin resistance by producing more insulin. However, in some women, the pancreas cannot compensate adequately. As a result, blood glucose increases and gestational diabetes develops. Risk factors include overweight or obesity, previous gestational diabetes, family history of diabetes, and previous delivery of a large infant. Management includes appropriate nutrition therapy, physical inactivity when appropriate, glucose monitoring, and pharmacotherapy when required. Next, epidemiology. Diabetes mellitus has become a major global public health problem. The prevalence of diabetes has increased considerably over recent decades. Type 2 diabetes accounts for the vast majority of diabetes cases. Several changes in modern lifestyle have contributed to this increase. These include reduced physical activity, increased calorie consumption, obesity, and urbanization. Another important problem is that many people with type 2 diabetes may remain undiagnosed for a long period. This is clinically important because hyperglycemia may already be causing vascular damage even before the diagnosis is made. Diabetes also increases the risk of cardiovascular disease, kidney disease, blindness, neuropathy, and lower limb complications. Therefore, early diagnosis and effective management is extremely important. Next, etiology of type 1 diabetes. Type 1 diabetes is thought to result from an interaction between genetic susceptibility and environmental factors. Genetic factors are important because certain individuals have increased susceptibility to autoimmune destruction of beta cells. The immune system mistakenly recognizes pancreatic beta cells as abnormal and begins attacking them. This autoimmune process may be associated with pancreatic islets autoantibodies. Environmental factors may also contribute to triggering the autoimmune process in genetically susceptible individuals. As the autoimmune destruction continues, the number of functioning beta cells decreases. Eventually, insulin production becomes insufficient. So, the sequence can be summarized as genetic susceptibility plus environmental influences leads to autoimmune beta cell destruction, which ultimately produces absolute insulin deficiency. Next, etiology of type 2 diabetes. The etiology of type 2 diabetes is more complex. It involves a combination of genetic and environmental factors. A strong family history increases the risk of developing type 2 diabetes. However, genetics alone does not explain the rapid increase in diabetes prevalence. Environmental and lifestyle factors are extremely important. Obesity, particularly increased visceral adiposity, contributes significantly to increase to insulin resistance. Physical inactivity also reduces insulin sensitivity. An unhealthy dietary pattern and excess calorie intake can contribute to weight gain and metabolic dysfunction. Over time, insulin resistance places additional stress on pancreatic beta cells. Initially, the pancreas compensates by producing more insulin. Eventually, beta cell function declines. Therefore, type 2 diabetes can be viewed as a progressive disorder involving both insulin resistance and beta cell dysfunction. Okay, next, risk factors. Some risk factors are non-modifiable. These include increasing age, family history, and genetic susceptibility. Other risk factors are modifiable. These include obesity, physical inactivity, and unhealthy dietary patterns. Hypertension and dyslipidemia are also frequently associated with type 2 diabetes. A history of gestational diabetes increases future risk of type 2 diabetes. Polycystic ovary syndrome is another important risk factor. Certain medications and endocrine disorders can also cause hyperglycemia. Next, pathophysiology of type 1 diabetes mellitus. The process begins with autoimmune destruction of pancreatic beta cells. As beta cell mass decreases, insulin secretion decreases. Eventually, there is an absolute deficiency of insulin. Without sufficient insulin, glucose uptake by insulin sensitive tissues decreases. At the same time, the liver continues to produce glucose through processing such as gluconeogenesis and glycogenolysis. Therefore, blood glucose rises. But the problem does not stop with hyperglycemia because insulin normally inhibits lipolysis. Severe insulin deficiency causes increased breakdown of stored fat. This produces free fatty acids. The liver converts these fatty acids into ketone bodies. When ketone production becomes excessive, metabolic acidosis develops. This is the basis of diabetic ketoacidosis. So, in type 1 diabetes, insulin deficiency causes both severe hyperglycemia and a tendency to cause ketosis. Next, pathophysiology of type 2 diabetes. The first major abnormality is insulin resistance. Skeletal muscle becomes less responsive to insulin, resulting in reduced glucose uptake. The liver also becomes resistant to insulin. Normally, insulin suppresses hepatic glucose production. When the liver becomes insulin resistant, glucose production continues even when blood glucose is already elevated. This contributes particularly to fasting hyperglycemia. Another important abnormality is progressive pancreatic beta cell dysfunction. Initially, beta cells may compensate by producing more insulin, but over time, this compensatory response becomes inadequate. There may also be inappropriate glucagon secretion and abnormalities in the incretin system. The kidneys can also contribute by continuing to reabsorb filtered glucose. Therefore, type 2 diabetes is not caused by a single defect. It involves multiple abnormalities affecting glucose regulation. Next, clinical manifestation. The first is decreased insulin secretion from pancreatic beta cells. The second is increased glucagon secretion from alpha cells. Third, hepatic glucose production increases. Adipose tissue shows increased lipolysis. Skeletal muscles demonstrate reduced glucose uptake because of insulin resistance. Renal glucose reabsorption contributes to maintaining elevated blood glucose. The normal incretin effect is impaired. Abnormalities in central regulation of appetite and energy balance can contribute to metabolic dysfunction. Mm, Next, the classic symptoms are polyuria, meaning excessive urination; polydipsia means excessive thirst; polyphagia means excessive hunger. When blood glucose exceeds the renal threshold, glucose begins to appear in the urine. Glucose in the urine draws water with it through osmotic effects. This produces increased urine volume. The resulting fluid loss causes dehydration and stimulates thirst, producing polydipsia. Patient may also experience fatigue, blurred vision, and unexplained weight loss. Recurrent infections and slow wound healing can occur. Importantly, some patients with type 2 diabetes may have few or no obvious symptoms. Therefore, screening and appropriate diagnostic testing are important in people at increased risk. Next, acute complications. This occurs when uh, acute complications. Diabetes can produce several acute complications. First is hypoglycemia. Um, when blood glucose becomes too low and is particularly associated with insulin or certain insulin secretagogues. The second major complication is diabetic ketoacidosis. Diabetic ketoacidosis is more commonly associated with type 1 diabetes and results from severe insulin deficiency. Next, hyper hyperslomolar hyperglycemic state is generally associated with type 2 diabetes and is characterized by severe hyperglycemia, profound dehydration, and increased serum osmolality. Both diabetic ketoacidosis and hypersmolar hyperglycemic state are medical emergencies. They require rapid assessment and treatment. Next, chronic complications. Persistent hyperglycemia can cause chronic complications. These are broadly divided into microvascular and macrovascular complications. The major microvascular complications are diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy. Retinopathy can eventually cause visual impairment and blindness. Kidney disease can progress to chronic kidney disease and in severe kidney cases, kidney failure. Neuropathy can produce numbness, tingling, burning pain, and loss of protective sensation. Macrovascular complications include coronary artery disease, cerebrovascular disease, and peripheral artery disease. Diabetes also contributes to diabetic food problems. Neuropathy can reduce sensation, while peripheral vascular disease can reduce blood supply. Next, diagnosis. There are several laboratory methods to diagnose diabetes. The first is fasting plasma glucose. If fasting plasma glucose of 126 milligrams per deciliter or higher is within the diabetic diagnostic range. The second method is the 2-hour oral glucose tolerance test using a 75-gram glucose load. The 2-hour plasma glucose of 200 milligrams per deciliter or higher meets the diabetic diagnosis criteria. The third is HbA1c. An HbA1c of 6.5% or higher is within the diagnostic range. Finally, random blood glucose of 200 milligrams per deciliter or higher together with classic symptoms of hyperglycemia or hyperglycemic crisis can establish the diagnosis. Next, prediabetes. Prediabetes means their glucose levels are higher than normal but do not meet the diagnostic criteria for diabetes. For fasting plasma glucose, the range is generally 100 to 125 milligrams per deciliter. For the 2-hour oral glucose tolerance test, the range is 140 to 199 milligrams per deciliter. For HbA1c, the range is 5.7 to 6.4%. Prediabetes is clinically important because these individuals have an increased risk of developing type 2 diabetes. They may also have increased cardiovascular risk. Weight management, increased physical activity, and appropriate dietary modification can significantly reduce the risk of progression to diabetes. Next, treatment goal. The first goal is to achieve individualized glycemic control. But glucose control is not the only goal. We also need to prevent acute complications such as severe hypoglycemia, hyperglycemic emergencies. We need to prevent or delay long term complications involving the eyes, kidneys, nerves, heart, and blood vessels. Another important goal is to reduce cardiovascular risk. Treatment choices can provide benefits beyond glucose lowering, including cardiovascular and kidney protection and weight reduction. We also need to consider quality of life, medication adherence, treatment burden, and cost. Therefore, diabetic management should be patient centered and individualized. Next, non pharmacological management. The first component is medical nutrition therapy. Patients should receive individualized dietary advice rather than simply being told to avoid sugar. The second component is physical activity. Regular physical activity can improve insulin sensitivity and increase glucose utilization by skeletal muscle. The third component is weight management. For patients who are overweight or obese, appropriate weight reduction can improve glycemic control and metabolic health. Diabetes education is also extremely important. Patients should understand their disease, medications, glucose monitoring, and recognition of hypoglycemia. Smoking cessation should be encouraged. Adequate sleep and stress management are also relevant to overall metabolic health. Therefore, lifestyle modification should continue even after pharmacotherapy is started. Next, medical nutrition therapy. The goal is not simply to completely eliminate carbohydrates, instead, focus on achieving appropriate overall dietary pattern and controlling energy intake. Patients should be encouraged to consume vegetables, fiber rich foods, and appropriate source of proteins. Refined carbohydrates and sugar sweetened beverages should be limited. The amount and type of carbohydrate should be individualized. Saturated and trans fat intake should also be minimized. Um, Dietary recommendations should also take into account cultural food habits, food availability, economic factors, and patient preferences. Next, physical activity and weight management. Physical activity has several beneficial effects in diabetes. When skeletal muscles contract during exercise, glucose uptake increases. Regular physical activity also improves insulin sensitivity. It can help with weight management and improve cardiovascular fitness. Patients with cardiovascular disease, severe neuropathy, food problems, or other complications may require specific precautions. Weight management is another important component. For patients with overweight or obesity, even moderate weight reduction can improve insulin sensitivity and glycemic control. Greater weight loss may provide additional metabolic benefits in appropriate individuals. Next, classification of anti-diabetic drugs. Anti-diabetic drugs can be classified according to their mechanism of action. The first major group is biguanides, um, example metformin. The second group is sulfonylureas such as glimepiride, glipizide, and glycoside. Next, meglitinides such as repaglinide and atiglinide. Next, thiazolidinediones, particularly pioglitazone. Next group is alpha glucoxidase inhibitors such as acarbose and voglibose. In addition, we have several new classifications. These include dipeptidyl peptidase 4 inhibitors, SGLT2 inhibitors, GLP-1 receptor antagonist, and dual incretin receptor. Thank you.